Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Dr. Moon, and I'm with Patrick O'Boyle as well, and we are going to talk about altitude illness and in the prolonged field care environment. How are you doing today, Richard?
Very well. Thanks for the opportunity to speak with you.
Outstanding.
As a word of introduction, I'm an anesthesiologist and pulmonologist. I work at Duke University Medical Center. I've been to altitude before. I've been to Everest Base Camp and higher a couple of times. I've been studying altitude physiology and medicine for a number of years, along with diving. And I have the opportunity to support not only special forces. I was very involved with Dr. Shapiro's program when he was here at Duke. Currently, I'm doing a project funded by the Navy related to altitude diving. So I have a strong interest in altitude. I'm delighted to have the opportunity to speak with you.
Outstanding, and we're appreciative that you can take the time to do so. Hey, Pat, if you wouldn't mind giving a quick intro.
Hey, good afternoon, folks. This is Patrick O'Boyle. I'm a senior medical instructor in clinical medicine at the JSOMTC. I've also had the benefit of working under Dr. Moon in the hyperbaric chamber and have grabbed onto his knowledge and tried to expand that a lot more, which he's been very gracious in giving me his guidance. And absolutely love being at JSOMTC and trying to bring in all this. Plus, I am the captain emeritus of a very large public safety dive team and have been working in somewhat of dive medicine for quite a few years.
Outstanding. So we got the right two guys. I think just to start it off with acute mountain sickness. Richard, what exactly is happening? Why is this kind of the nausea, the vomiting, insomnia, things like that? Why does that happen at altitude?
Well, that's $1 million question. We know quite a bit about what the symptoms are, and we know how to treat them. We know very little about the mechanisms. We know that in the setting of altitude, certain things can certainly make you sick. High altitude cerebral edema, brain swelling. Obviously, under any circumstance, brain swelling is going to cause headache, nausea, and vomiting. Why the brain swelling occurs is not known. And similarly, high-altitude pulmonary edema is very poorly understood. There is some suggestion that it's related to a combination of the inflammation that might come from, let's say, a cough or cold or mild bronchitis, and exaggerated increase in pulmonary artery pressure, which does occur in everybody under hypoxic conditions. Some people, their pulmonary artery pressure goes up to a greater extent, and there's some evidence that those individuals are at greater risk of developing HAPE. Now, the more common condition, acute mountain sickness, basically nausea, vomiting, malaise, is very poorly understood. Why in those individuals it's not believed that they have HACE, although some people think that it's maybe mild HACE, but certainly it's not lethal. Depending on how high one goes and how fast one gets there, almost everybody can get AMS, which generally resolves over 2, 3, 4 days. So again, we know what these syndromes look like. We have a very poor understanding about why they occur.
Do you think it could be, because usually they say, hey, it happens at 8,000 feet or greater. Do you think it has more to do with the delta, the change in altitude, or is there just a magical hard ceiling at 8,000 feet?
No, there's no magic seating. I mean, Colorado Springs is close to 8,000 feet, and most people can fly from low altitude into Colorado Springs and have a nice time without much of any symptoms. It's absolutely the delta and the rate. So if you, let's say, I would say at 15,000 feet, most people will get acute mountain sickness if taken there very quickly, let's say in a helicopter. But if you climb to 15,000 feet, there's very little of anything, at least in terms of AMS. Now, of course, HAPE or HACE could occur in those small percentage of people who are susceptible, but AMS not so much if you go very slowly. So it's both the rate of climb and the delta height.
Okay. So, we've talked a little bit about the different symptoms of each syndrome, but where does it cross over from AMS to, say, cerebral edema?
Cerebral edema is a condition that was at one time, if you look at the old literature, it's a relatively rare condition, but in my experience, it's fairly common. I've seen several cases of HACE in my relatively brief experience at high altitude, and it can look like anything from headache, ataxia, difficulty walking, with loss of consciousness, all the way from that to just mild unsteadiness on the feet. One case I saw when I was on the way to Everest Base Camp was a guy who, on the trail, looked like he was drunk. I thought, well, this guy's obviously had a few too many. But when we reached him, there was no alcohol on his breath. He hadn't been drinking, and it was pretty clear that it was due to a mild case of HACE, and we were able to get him out. Another instance was young woman, she was about 31 or 32 years old, who slowly went blind, and we were able to get her out. She was completely denying her symptoms. She was vaguely able to follow the path by looking at the person in front of her and sort of making sure that she took the same steps. And she was repeatedly asked if anything was wrong. She said, no, I'm absolutely fine. So denial can be part of it. But it was clear, she was not normal. The easiest test to do is to get someone who's suspected of HACE to try to walk heel toe. In other words, stand on relatively level ground if there is any to be had, and just walk heel to toe. And most people can do it, of course, but if there's some problem doing that simple task, then suspect HACE may be part of it. HACE is a different animal entirely, which is respiratory. So the individual is going to be short of breath, maybe coughing. When you listen to their lungs, they've got crackles. Interestingly enough, the first place that HAPE tends to be evident is over the right middle lobe. So we're all, when we use our stethoscopes, we're all accustomed to listening to the back of the person, but it's also useful to bring the stethoscope around right under the right breast. And sometimes you'll hear crackles there, but you won't hear them anywhere else, at least with early HAPE.
So just quick backtrack to cover HACE. General treatment is with dexamethasone. Other than just the steroid, is there anything else that I can be doing?
Well, there are a couple of things. One is, of course, descent is the standard, the gold standard. One thing is to give supplemental oxygen if available, which does the same thing as descent. And the other, of course, is if you've got a portable hyperbaric chamber like a Gamow bag, you can lower the effective altitude by 2,000 or 3,000 feet by pumping up the bag to I've forgotten what the actual pressure is, but it's a couple of psi. It's not much, but it does lower the altitude and raise the PO2.
Okay. So when it comes to descent, what if I'm not able to completely descend and just return to base, but I can descend, 500 feet or 1,000 feet, and still be in a safe location, and kind of stabilize things there? Is that going to be enough, or could it be enough?
Well, it depends on the person, of course. Yes, if you can get a descent of 500 or 1,000 feet, that's potentially useful.
Okay. Now the Gamow bag, it's not a small thing that I can throw in my pocket. So that's definitely going to take prior planning. Also, it's pretty cumbersome if there's other injuries besides the altitude illness or the haze, just because it's limiting as far as drugs and things like that, or administration of drugs, assessment of the patient. So in order to do those things, you would have to kind of open that bag back up, do whatever you need to do, and then repressurize it. But with planning, that's, if that's your plan, then enact your plan. As far as haze, I guess those are pretty much your only two real options, but it seems to center around just administration of oxygen, either through descent, or increasing oxygen either through descent, and or administration of oxygen, and trying to reduce inflammation with a steroid. Is that pretty much sum it up?
Yes, no, exactly. Dexamethasone can be dramatically effective. One of my colleagues, a young woman again, had experienced haze. A group had gone up from near base camp to it's another 1,500 feet to the top of Kalapatar, which is a great place to be because you can see the four peaks, you can see Everest. I didn't go on that occasion, but when she came back down with the group, she looked absolutely deathly. I thought, my God, what am I going to tell her husband when she is coming back? But she was given dexamethasone, and several hours later, she was good to go and hiking along the trail. Of course, if somebody has impaired consciousness, oral dexamethasone may not be possible to administer. So intravenous dexamethasone is a nice thing to carry with you.
Here's another dumb question: is there anything is physiologically different between the HACE, the cerebral edema from altitude, or the kind of the inflammation that happens with the TBI, let's say a concussion or even an actual TBI? If I don't have dexamethasone for whatever reason, could I use a hypertonic?
Well, that's a great question, and I don't know the answer to it. It's a difficult thing to study, and but that's a great idea, and I guess I would try it if I didn't have dexamethasone.
Right. If nothing else, you're probably not going to make it much worse, right?
Well, that I don't know.
Right. Well, hopefully I'll never have to test it out either. Let's move on to HAPE. Okay. So obviously kind of hallmark with that, you get you start getting fluid buildup in the lungs. Now, is that because of the pulmonary hypertension, or what's the mechanism for that?
Yeah, well, if you measure the change in pulmonary artery pressure amongst a group of people who are susceptible to HAPE. And I'll say as an intro, HAPE susceptibility in the North American population is about 2% of individuals. And if somebody is susceptible to HAPE and they go high enough, fast enough, they're going to get it every time. If somebody is not susceptible to HAPE, they're probably not going to get it. So it's an individual susceptibility. It's not clear that that's the case for HAPE, but certainly it is for HAPE. Now, if you take a group of HAPE susceptible individuals and you measure their pulmonary artery pressure in response to a hypoxic challenge, so you give them, let's say, 12% oxygen to breathe for a few minutes, and you measure the increase in pulmonary artery pressure, and you compare that with a group of people who are not susceptible, the ones who are susceptible have a higher, in general, although there's quite a bit of overlap, in general, their pulmonary artery pressure does go higher. And so that's the reason for thinking or hypothesizing that high pulmonary artery pressure may be part of the pathophysiology. But it's probably something else as well, because if you're at altitude and then you start exerting yourself, pulmonary artery pressure goes even higher. And there are lots of people who have exceptionally high pulmonary artery pressure who don't get HAPE. So exactly what it is that causes it is not understood. But we do know that agents, drugs that lower pulmonary artery pressure tend to be helpful in the treatment of HAPE, such as nifedipine. And nitric oxide has also been used, inhaled nitric oxide, although, the average military detachment at altitude is not going to be carrying a tank of nitric oxide. But other things like sildenafil have been used as well. And so pulmonary artery pressure probably plays at least a role in HAPE.
So you mentioned susceptibility. Is there anything in particular that makes somebody susceptible, or did they just win the genetic lottery?
Yeah, well, I think that's it. Choosing one's parents indiscriminately for whatever reason can make someone susceptible. It seems to be genetic, but exactly what's going on, we really don't understand. Okay.
So you mentioned, Viagra or Cialis, nifedipine. So if I understand it correctly, they're going to reduce my pulmonary hypertension, or that's the goal of it, and thus at least reduce the amount of edema. Will that is that going to be enough to actually allow the body to start reabsorbing it, or am I going to have to use some other mechanism to actually start pushing that fluid back out of the lungs?
Well, it's a tough nut to crack, because when we deal with pulmonary edema due to heart failure, of course, a first line drug is a diuretic. Mm-hmm. That's not recommended for HAPE, because what that's going to do is just dehydrate the individual. The HAPE is due to localized edema, and so reducing total body water is going to be counterproductive. Some agents, like beta-2 agonists, inhaled albuterol, for example, conceivably could help facilitate reabsorption of water, because the beta-2 agonists stimulate the sodium-potassium pump that helps get water out of alveoli. And there's some evidence from tissues, from the human lung tissue, that might be helpful. And it's a very benign thing to do, to give somebody a few puffs of an inhaler. The problem with HAPE is that it's double trouble. So we know that it's caused by hypoxia, but when the lungs fill up with fluid, it makes hypoxia much worse. And so it's not unheard of for individuals with HAPE to subsequently develop HACE, because now you've functionally increased the altitude by lowering the arterial CO2 below that which would normally be the case for a given altitude.
And Dr. Moon, on these agents for HAPE that we just discussed, is that something we would recommend as a prophylactic treatment or upon the slightest manifestation?
Well, there's not really much you can do to prevent HAPE, although, I mean, if for some reason you had to take somebody who is known to be HAPE susceptible to altitude, you'd probably want to try prevention with, let's say, sildenafil or tadalafil, steroids, dexamethasone may be somewhat helpful to help for prevention of HAPE. But if you know that somebody is susceptible, you probably want to keep them out of altitude to begin with.
Yeah. Okay, good. I was just in reference to Diamox, as we do that as a prophylactic, coming out being a carbonic anhydrase inhibitor, and that's it. Because opposed to conventional forces, sometimes our teams don't have that time value before they need to respond to altitude. Okay, I'm back to that.
Yeah, no, that's fair enough. And if you're going to send someone to altitude right away, in an hour, and you're going to go in a helicopter, so the delta altitude is going to be high and it's going to be fast, I would absolutely recommend acetazolamide, because at the very least, those individuals are going to potentially get AMS. And AMS, if you're feeling like hell, you're not going to perform well. And acetazolamide is a pretty benign drug. I would absolutely use it.
Now, I've also heard on another podcast I'll link to in this podcast is that, even if you're not using acetazolamide for either pre-treatment, but taking maybe a smaller dose for sleep is definitely beneficial.
Yeah, well, prophylactic doses of acetazolamide, 125 every 12 hours, are pretty benign. The other drug that you might consider for prophylaxis of AMS is dexamethasone, where if you randomly give dexamethasone a lot to a lot of people, someone could develop a complication. But if you've got to do an emergency altitude trek or go to altitude very quickly, and you know that the guys are at risk for AMS, they've had it before, giving dexamethasone a couple of milligrams every 6 or 4 milligrams every 12 hours is a reasonable thing to do for short term.
Understood. I routinely take sildenafil just for the just to make sure if I do have to go to altitude, I will be covered.
Yeah, that's right.
So other than, we mentioned nifedipine, sildenafil, Cialis. Cialis has a 12-hour versus sildenafil is an 8-hour coverage. So it might be a little bit easier to control that with Cialis. And Descent, okay, we mentioned albuterol as well to help start clearing up some of that pulmonary edema. Would you use artificial ventilations if this patient is starting to succumb to that hypoxia, or maybe even breathing exercises to help keep the alveoli open?
Yeah, well, if you've got somebody with HAPE at high altitude and you can't get them out, try anything. I will say, by the way, that tadalafil and sildenafil may be useful for HAPE prevention, but they're not going to be useful for anything else. They're not they're not going to prevent HACE or AMS. There's been some interest in whether sildenafil or tadalafil might increase PO2 by reducing pulmonary artery pressure, and the evidence for that is plus minus. There have been some small studies suggesting that it might actually improve oxygenation, but others showing no significant effect. But certainly, if you had to take somebody who is HAPE susceptible to altitude, I would definitely give either one of those, one or the other of those drugs.
Okay. So things like pain management. So definitely some of the signs and symptoms are headache. Are there any medications I need to avoid for certain?
Well, I would use narcotics very gingerly, if at all, at altitude, because narcotics will depress respiration reproducibly and will therefore lower PO2. So if you're trying to treat headache with AMS, then giving a narcotic is not your recommended treatment. But ibuprofen is fine. Acetaminophen is fine. Those are the drugs that you want to use for pain.
Okay. Now, how about not for necessarily the headache itself, but patient has an injury of some kind as well? What about things like ketamine or ketamine Versed? Will those have any effects at altitude?
They haven't been studied a whole lot, although ketamine for anesthesia has been used at altitude because it's a one drug wonder. You can use it for almost anything. It tends to depress respiration less than opioids, and if you need some quick analgesia for something like let's say putting a splint on a fractured bone, a small dose of ketamine is a reasonable thing to do. Or if you're someone's got their leg jammed between two rocks and it's excruciatingly painful to try and get it out, then a small dose of ketamine might be just the thing. The other thing about ketamine is that it tends to depress airway reflexes less than other drugs. And so it's safer than other consciousness impairing drugs. So let's say you wanted to use propofol or a large dose of Versed. Those drugs are relatively less safe. Now, if your question related to giving Versed before giving ketamine to avoid some of the dysphoric effects, I guess a small dose of ketamine would be okay. A small dose of Versed, rather, would be okay. But generally speaking, if you're trying to avoid dysphoria from ketamine, you need a relatively large dose of Versed, and I would use it gingerly. Now, if you're at high altitude and you're all set up with monitoring and oxygen and whatever, then by all means go ahead and use those drugs. But if you're out in the field, I would be very hesitant to use Versed.
Understood. So let's say you're the doc at Base Camp Everest. And we have a patient coming in. Somebody's telling us, hey, he's got some kind of altitude illness. We're not sure if it's AMS, pulmonary edema, cerebral edema, but there's something wrong, and they're bringing him to you. The weather is not that great, so if you have to evac, it's not going to be a benign thing. So somebody's going to be at risk. So you actually have to think about whether it's worth it or not. what would be your kind of decision point to say this person needs to be evac'd versus we're going to hold tight here?
Well, the first thing I would do, if I thought they had hate, then I would do everything I could to try and treat the condition as best as possible with inhaled beta-2 agonist, if possible, nifedipine or sildenafil, if I had those drugs, just to lower pulmonary artery pressure and hopefully get some action there. If I'm trying to decide between AMS and HACE, I would do the walking test if I could find a piece of flat ground. And either way, I would give dexamethasone, because dexamethasone is good for AMS, it's good for HACE, and it's pretty benign. In terms of evacuation, if somebody started to lose consciousness despite what I was doing, then I think that would cause me to pull the trigger, because that individual is at high risk of dying. And if they're not treated, if you don't have oxygen, then I would do whatever possible to get the individual out.
Outstanding. That was gold right there. Is there anything else that we need to know about high altitude illness before we go?
Well, I think you've covered the spectrum pretty well.
And that's why I'm the host.
Dennis, if I can add one thing.
Sure.
When I approached Dr. Moon and asking us for his time today, he did send me a paper from the Wilderness Medical Society of Andrew Lux of 2019. And I know you have a very large fan base and a listening group, but the Wilderness Medical Society, Dr. Lux 2019, actually goes into acute altitude illness, and it's an update, and it is in a format that is fairly easy for the sole provider that's out there with the teams. And I think Dr. Moon will probably just add a little bit. It's probably saying, it's a good read. It's something good to have for that. And Dr. Moon, would there be any other literature that you would recommend to Dennis's listeners?
There are several papers around that are very good. That particular one is excellent because it's up to date and it provides guidelines as to what to do. I'm happy to share my collection, but authors such as Peter Hackett. Peter Hackett basically wrote the book on altitude illness, and there are several other authors as well. Every few years, there's a very nice review article in New England Journal or British Medical Journal, other places, and I'm happy to send you some if you're interested. Pat, I've got your email address. I can fire you 3 or 4 useful references if you'd like.
Oh, that would be wonderful, and I can get it to Dennis where he can. Dennis can get it out to the masses.
Yep, absolutely. Another good source, I just listened to the Dust Off podcast. They did a really good job with their altitude illness episode, and I stole some of their questions as well. So, I really appreciate it, Rich, for your time.
My pleasure. Anytime.
Outstanding. Hey, thank you, Pat, for helping out.
Oh, absolutely. And thank you, Dr. Moon, for your support of Special Forces.
Absolutely. Anytime.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.